Dear students of the second year dentistry, we are before the end of the summer term of our topic, of our subject, topography of head and neck. The last chapters comprise the arterial hemorrhages, ligation of arteries, and then some topographic regions of the neck. Starting now with the chapter arterial hemorrhages, we remember that the hemorrhages represent a complicated situation which is of serious value for the patient. We know that in some cases, rupture of the skull, rupture of the tissues can lead to the bleeding. So as we see on the simplified diagram, we see the drops of the blood and bleeding. So the way is to either to compress the artery or to make a ligature, so to ligate the arteries. Of course, speaking always about the collateral system, which provides the normal blood supply of target area. Starting with some arteries of the head and neck. Number one is the common carotid artery. To each artery, we could say some notes if it's possible to make any ligature or even to compress the artery. So starting with the compression. Yes, compression, common carotid artery lies on the neck. We know that we can compress the transverse process as we could read it. Transverse process of the cervical vertebra number 6 at the level of the cricoid cartilage, and approximately 3 centimeters from median plane. So we can palpate from a median plane the level of the cricoid cartilage, and we are at the level of C6. We remember that the bifurcation of the common carotid artery lies at the level of C3. External carotid artery is the artery which runs ventrally. Here on the diagram, we see the level of C3, C4, anteriorly ventrally external, then posterior internal carotid artery. And as a help in the orientation is the superior thyroid, which lies at the level of bifurcation. So we know that we cannot compress the internal carotid artery because it supplies the brain. We can compress the external carotid, and we have to pay full attention to the fact that the bifurcation contains the carotid body, which contains the chemoreceptors, and the wall of the carotid sinus contains the baroreceptors. So this is just the information for this artery, just compression, internal carotid without any touch. Number 3 is the lingual artery. Lingual artery is a specific artery important for dentistry. So we know that the lingual artery as the ventral branch of the external carotid artery runs dorsoventrally behind the greater horn of, or above the greater horn of the hyoid, then passes cranially to supply the muscles of the tongue. Concerning the position of the artery, just for orientation, here we see the hyoid bone to which is attached the raphe of the mylohyoid muscle forming the floor of the oral cavity. Then important for the position is the course of the digastric muscle, anterior belly, posterior belly. Posterior belly runs together with stylohyoid, which splits out into 2 parts, and in the small cleft passes the digastric. This is what we remember. Concerning the exact position of the artery, we describe the angle of Benclard's angle, which is formed by the bellies, both bellies of the digastric, and inferiorly better by the posterior belly of digastric and the greater horn of the hyoid. Discussing the anterior belly just for better orientation in the area. And here you see that the artery passes into the Benclard's angle. Better is to say that the posterior belly plus the stylohyoid form one arm of the Backard's angle of Backard. The second one is the trigone, roughly trigone of Pirogov, which is the same. We are above the hyoid bone, we are in the higher position. That means between the bellies of digastric plus, as you see also in the first drawing, looking at the course of the hypoglossal nerve. So together with hypoglossal nerve, we are in the trigone of Pirogov. So this area is exactly the area where we can compress and also make an incision in order to make a ligature of the lingual artery. The next one is the facial artery. We know that facial artery supplies the face, crosses the mandible, and is accompanied by the vein of the same name. The artery lies on the or crosses the mandibular body, better the inferior margin of mandible. Concerning the topographical relations, dorsally we see the masseter, then the margin of the body of mandible. Then below that lies the submandibular gland. And we said that the facial artery runs together with facial vein. It's true. The difference between them is that the artery passes usually through the gland and appears on the margin of the mandible, while the vein lies on the surface. So both run together. Then crossing the mandible is the place where we can feel the pulsation of the artery, as we can read it, and then goes up, giving off the branches to the lips. That means the superior inferior labial branches ascending towards the medial angle of the orbit, so as the angular artery together with angular vein. Details are quite clear. The level, this is the level of the bone of the margin mandible, and here is the level where it usually appears from its course through the submandibular gland, which is around 8 to 10 millimeters. We have to take also in consideration that here runs, just putting some dots, also the nerve. This is the ramus marginalis mandibulae, marginal branch of the facial nerve, which leaves the parotid gland, and also at this level, the artery crosses, together with the vein, crosses the position of the marginal nerve, ramus marginalis of mandibulae. Next artery is the maxillary. We know that the maxillary artery is specific because we know that the maxillary artery crosses the medially the neck of the mandible. So the fact is that we are considering the position and course of the branches of the cranial nerve, number 7, but they are situated more superficially, so they pass through the parotid gland. So the maxillary artery, we remember, is the terminal branch of the external carotid. When we look on the next diagram, the artery runs like that, while the second terminal branch is the superficial temporal artery. So maxillary is not on the situation which, or is not on the surface, close to the surface. Concerning this next one, superficial temporal artery, the artery passes through or behind the tissue of the parotid gland. The artery runs together with the vein of the same name and auriculotemporal nerve. So all three structures run together in front of the tragus and behind the tissue of the parotid gland. So incision is vertical, and in the same area we can make the ligature of the artery in case of bleeding. More complicated is the following artery, which is the major palatine artery, arteria palatina major. The major palatine artery, as you see in the simplified diagram, It runs together with the small vein and the nerve of the same name, and the artery runs ventrally. It lies in the groove, relatively in deep position. You probably remember the zones of the palate, of the tissue covering the hard palate, and one of the area is this groove. You see, this is that level. We are at this level, so artery lies inside the groove, and it's difficult to make an incision. It's possible, usually using the special tools, which is a hook after the incision, which runs in longitudinal direction. So we see here that relatively deep position of the major palatine artery. The next artery is the inferior alveolar. Also, we know that inferior alveolar artery passes on the medial side of the mandible. The artery could be damaged, leading to bleeding after complicated extraction of the posterior molars. Ligature is not possible, we know, because it lies in the canal. So they usually make ligature of the external carotid artery, which is logical in all these cases. The same is with the maxillary. Not artery, but there is also one possible bleeding in after damage to pterygoid plexus. It could be made by the anesthesia of superior posterior alveolar nerves when the needle is in the infratemporal fossa, gliding on the posterior surface of the tuber of maxilla, and then, because it's a network of fragile tissue, the network of the venous interconnection and the connective tissue, so then it can lead to bleeding, as we can read together. The only way is to make a tamponade into the posterior angle of oral vestibule. So these are the information concerning the anatomical points where we can compress, or if it's possible also to make a ligature of the arteries in case of bleedings. No? And then finally, next area is the suprasternal region. As the name says, the suprasternal region, as we can look at this very simplified drawing by sufficient. This is the sagittal section, and we could see that when we look at the diagram, the suprasternal region lies above the sternum, bounded by we see 1, 2 laminae. These are 2 laminae of the fascia of the neck, and important for us is to see the fact that between these 2 laminae, one is ventral, which is the investing fascia, superficial. One is pre-tracheal lamina. So there is a space, triangular space, in which we see usually some veins forming the venous arch from the anterior veins of the neck. And important for us also to see some superficial veins. And the most important fact is that here is the place of the coniotomia, or also we call it also laryngotomia. Coniotomia is based on the older name of the conus, not conus elasticus, but it was called the thyrocricoid ligament. It was the ligament which was called the ligamentum conicum. Details are not necessary. We remember that here is the cleft where we can cut or make an opening of the lamina of the ligament, and in the case of the risk of suffocation, we can make a fissure cleft for bleeding, for respiration. Sorry, small bleeding from the small veins is not necessary, or is not necessary to take in consideration. The second one is the tracheotomia. Tracheotomia means the vertical incision made either above or below the isthmus of the thyroid gland. That's why then we call it superior. This is the inferior tracheotomia, fully in the hands of the surgery. The importance of this area is, as we said, in these two steps, conio or laryngotomia and tracheotomia. In subcutis, run, as we said, in the lateral region of the neck. Remember the superficial veins and transversus coli nerve. Transversus coli is the nerve which runs from the punctum nervosum neural point dorsoventrally and innervates the superficial layers of the region. So just simply suprasternal region is that region situated above the sternum and formed by two laminae, and important for us to remember that there are two important approaches to the trachea, avoiding the risk of suffocation. So this is the suprasternal. No? And then following is the lateral cervical region or lateral cervical area, or also trigone. When we look from on front for better orientation, we see the hyoid. Here is the clavicle. Then dotted line indicates the position of sternocleidomastoid, and dorsally, again, the solid line indicates the anterior margin of the trapezius. So concerning the terminology, we remember that if that, thus placing the point, if that muscle is trapezius, so trapezius in fact belongs to the back of the neck, so is not neck region. So this trigone situated here and bounded ventrally by the sternocleidomastoid, dorsally by the trapezius, anterior margin, inferiorly by clavicle. So this space is called lateral cervical region. The lateral cervical region is divided, as you see, by descending or ascending, as we can see, muscle omohyoid, because it's omohyoid, ascending from the scapula to the hyoid bone, divided into two trigones. One is larger, much bigger. This is omotrapezial region, and the small trigone, more important for us because there are more structures, is omoclavicular, smaller trigones. So these two trigones form the lateral cervical region. Looking at the layers, looking at the superficial topography, we can look at the first of all the superficial, and then later on the deeper layers with different contents. Usually very thin skin, then follows the platysma without its own fascia, then follows superficial fascia or investing fascia, fascia coli, and then they are the superficial structures like the external and anterior jugular veins. They form usually the arch, angulus venosus, venous angle. They interconnect the contralateral sides. And also we remember that there is a place we said, and this is what we could see, is not seen on the diagram, but the places. Exactly here is the punctum nervosum, from which ascend the occipitalis minor, auricularis magnus, that one, transversus coli, transversally, with the superior branch, inferior branch, and then the supraclavicular, just dotted lines indicating three of them, lateral, intermediate, and medial group. These nerves innervate the subcutis or superficial layers in this infraclavicular region. So this is that punctum nervosum from which run or ascend the branches of the cervical plexus. Concerning the position of the punctum nervosum, is important to remember that because it's a neural point, sometimes in case of anesthesia, we have to take in consideration that the tip of needle cannot be deeper than around 3 to 4 millimeters. We know why, because here runs the nerve, the phrenic nerve. We remember that the phrenic nerve lies on the anterior surface of the anterior scalenus. So we can draw dotted line showing how does it run in this direction, passing between the subclavian artery and vein, and then running in the thoracic cavity. So this is the phrenic. So there is a risk of phrenic injury, nerve injury, if the tip of needle will be deeper than 3 or 4 millimeters. And finally, there are also lymph nodes. They are situated, we see them in light green. They run forming simple chain of the lymph nodes alongside the cranial nerve, number 11, accessory. So that's why we have here written CN11 plus lymph nodes, and also alongside the transversa colli. So here we see the branches which belong to the thyrocervical trunk, just in front of the interscalenic fissure. We remember that interscalenic fissure is the cleft between the anterior middle scalenus in which or through which passes the subclavian artery, and we don't see it here, the brachial plexus. In that direction descends the brachial plexus. And from the thyrocervical trunk, ascending cervical, superficial cervical artery, transversa colli, and finally suprascapular. They could be variable in different cases. And note please that subclavian vein lies in front of the scalenus anterior. So that's why it doesn't pass through the interscalenic fissure, just the artery plus brachial plexus. So these are the structures found under the investing superficial investing fascia. So these are the deep structures. No, the last diagram, last topic in the topographic anatomy is the trigone, which is called scalenovertebral region, or scalenovertebral trigone. The trigone, when we look from on front, is bounded anteriorly by the sternocleidomastoid, then dorsally posteriorly by the longus colli, long muscle of the neck, then laterally, here lies the scalenus anterior, and inferiorly the floor is formed by cupula of pleura. Here for better orientation lies the clavicle. So there are the boundaries. Medially, there is the median plane. In the median plane descend, as you see, the trachea and esophagus with accompanying structures. So we see the boundary. So in fact, the region contains all the structures which are found on the base of the neck. That means, as we see here, we have the cranial number 10, then phrenic nerve, definitely, and then the internal jugular vein, and of course, the common carotid artery. Concerning the boundaries, we said the cupula of pleura lies around 2 centimeters above the medial end, the sternal end of clavicle, or around 4 centimeters above the first rib. First rib is usually covered by clavicle. Boundaries we know, based on the general agreement, it descends from C6 to cupula of pleura. Concerning the contact of the cupula with the following structures, we have to mention subclavian vein, subclavian artery with the branches, then brachiocephalic trunk, then the thoracic duct. We remember the thoracic duct ascends from the thoracic cavity behind the large vessels and entering on the left side, the left venous angle, running dorso-caudally on the left side. Then vagus nerve. Vagus nerve descends together with the phrenic nerve between the subclavian artery and vein. We remember that these two structures descend from the base of the neck into the mediastinum, and they are situated in the narrow cleft between the row of the veins and row of the arteries. That's why we have mentioned subclavian artery, subclavian vein. Phrenic nerve together, we know that phrenic nerve runs laterally to the vagus, and then descends to the lateral surfaces of the pericardium, and then descending directly to the diaphragm. No, and the deepest structure is the sympathetic the trunk, which lies within the duplicature of the prevertebral lamina of the fascia of the neck. So this is the last topographical region of the neck, and what still remains is the last chapter in the topographic anatomy of the neck, and this is short review of the defects. We call it developmental defects, or development of the palate and branchial arches, and with some developmental defects. We know that we start with the palate, and we know that the palate consists of the palatine, is formed by the palatal processes of the maxillae and horizontal plates of the two palatine bones. Anteriorly, we see the premaxilla. Here we see the processes, lateral ones. They join together at the level of the median suture. The situation is, if everything runs normally, so then the processes are first of all more vertical. Then in the following steps, they change the position in the horizontal. We call it palatal, or horizontalization of the process of the processes that they finally join together. So we see 3 steps: vertical position, then horizontal position, and the final diffusion, which lies in fact at the level of median suture. This is what we said. If not all the things run well, then we describe the abnormities, abnormal development, and they are various degrees of failure of fusion of palate bones. So the process can comprise these 2 normal steps, but the last one, the fusion, is not complete, and it results in the clefts of the lip or cleft of the palate, preferably. So this diagram shows the abnormities, as we said. First of all, we could see that if the fusion is not complete on one side, or this one, the other one is incomplete fusion causes the cleft palate on one side, unilateral, or on both sides. That's why we call it bilateral. The cleft can comprise the cleft of the palate, but also the cleft of the lip, as we see. So cleft lip on one side or on both sides. The variations depend, as written here, on the failure in fusion. They could be many variants. Factors influencing the abnormal development are preferably hereditary, genetics, or environmental. Cleft palate found in the ratio 1 to 2,500, preferably in girls, and cleft lip in opposite at birth, preferably in boys. The ratio is 1 to 1,000. So now is well known now that generally accepted now, the main etiological factor of developmental defects of the lip and palate is genetic factor. This is the first group. There are also developmental defects of the tongue. tongue, we know that is relatively complicated structure. We remember the musculature of the tongue, different nerve supply, different lymphatic drainage, different blood supply of different parts. We can see development from the 4th week, and from that time are possible the malformations of the tongue. Number one is the ankyloglossia, is shorter tongue, which is based on the shorter frenulum, shorter lingual frenulum. Here you see the frequency. The treatment is phrenotomia, so just cutting the frenulum usually improves the situation. The second big group is the macroglossia. It's based on the hypertrophy of musculature of the tongue. And the next one is the micro. So macro is larger, microglossia is in fact under development, usually associated with other defects like the micrognathia. That means there is a shorter mandible. So this is a complex of defects. So this was the second category, developmental defects of the tongue. And the last one is the development of pharyngeal arches. Again, details are not necessary. We know or remember, and you studied it also in the histology embryology, that the pharyngeal arches, as we could see on the following and last diagram, the pharyngeal arches consist of, just short revision, excellent. We see the arches 1, 2, 3, 4, 5. The arches consist of the material based on the endoderm, ectodermal material. Each arch consists of the cartilage, artery, nerve, muscle. The complex is seen here, and the arches contain the depressions on the internal side. We call it pouches, and the pouches represent the material which gives rise to the following organs. The first one is the external acoustic meatus and auditory tube. Then the next one is palatine tonsil. Then the third and fourth pouch gives rise to the parathyroid glands. It's true, they change in the development. So from third and fourth, they change. This upper one goes caudally and vice versa. Then from the fourth one, usually from the bottom, also develops the thymus. And finally, from the last one is the ultimobranchial body, which are in fact the cells which are found in the thyroid gland. We remember as the small cells, parafollicular cells producing calcitonin. No, so this is normal. But in some cases, usually the lateral in a larger, deeper medial pouch depression, better to say depression, is usually not interconnected. But in some cases, the canals, the narrow canals, can persist after the formation of the pouches, and persisting tubes are called fistulas. Fistulas are found usually on the anterior side alongside the anterior surface of the sternocleidomastoid and the lateral side, or they are found as a cysts in the same area. So location, as we said, is alongside the sternocleidomastoid. And another type of defect is are the cysts found in the thyroglossal canal, which remains after the descent of the thyroid gland from the base of the tongue to its target area, orientation, target position. The fistulas and cysts are found on the lateral or on the central median part of the neck. No, and we are at the end. Of course, the repair of these defects is fully in the hands of surgeon. Usual defects are more complicated, like syndromes, and they can affect the first arch, second arch. That's why we call it first arch syndrome defects, which has so many symptoms. The most frequent is really the first arch we remember this is called mandibular. But as we said, more details you can read in the embryology, but this is just short review of the main things. So this is the end of our introductory text. We will remember that the topographic anatomy of the head and neck comprises important regions. This is the most important for you to know the contents of the regions, including the orbital region, orbita, then the internal middle and internal ear. So these main sense organs. Then the review of the main areas. Very important is the blood supply to each area or the nerve supply. So I mean that we completed everything in order. Thank you for attention. Wishing you all the best and full success in your presentation of the knowledge in the phase of the studies. That means the exam. Thank you.